So whenever you want, Dr. Mahmood, we can start. And thank you again for taking the time to join us.
Of course, thank you for having me, everyone. So today we're going to talk about cardiomyopathies and heart failure with preserved ejection fraction. So this is the outline for the lecture. We'll go over several cardiomyopathies, the difference between cardiomyopathies and heart failure. And then what we're going to go over is dilated cardiomyopathy, hypertrophic cardiomyopathy, restrictive cardiomyopathy, arrhythmogenic cardiomyopathy, and then unclassified. Then we'll go over the difference between diastolic dysfunction and heart failure with preserved ejection fraction. And then we'll delve a little bit more into HFpEF, definitions, incidence and prevalence, prognosis, pathophysiology, and treatment. And then we have a few questions towards the end. So the definition of cardiomyopathy. So this definition has changed throughout the years, and it started off in 1980, defined by the WHO as a heart muscle disease of unknown cause. And currently, the most recent definition that we will focus on is the myocardial disorder in which the heart muscle is structurally and functionally abnormal in the absence of coronary artery disease, hypertension, valvular disease, and congenital heart disease, sufficient to explain the observed abnormality. And there's various structural and functional phenotypes, and this is frequently genetic. So a lot of times you will hear, especially in us talking about ischemic cardiomyopathy and non-ischemic cardiomyopathy. Those are actually not defined by the AHA or ACC as cardiomyopathies per se. So this is really a heart muscle abnormality, not in the setting of coronary artery disease, hypertension, valvular disease. So we're focusing on a different subset of diseases and pathology, and you can see like where this nomenclature kind of like is all over the place and it's a little bit confusing, but we'll sort of try to simplify it a little bit here. In 2006, the AHA definition of cardiomyopathy was a heterogeneous group of diseases of the myocardium associated with mechanical and or electrical dysfunction that usually exhibit inappropriate ventricular hypertrophy or dilatation due to a variety of causes that are frequently genetic. This can be confined to the heart or be a part of a generalized systemic disorder. And 2008 definition is the one that I just went over, which is the most recent one by the ESC. So in 1980, when the WHO came up with this definition of cardiomyopathy, it then classified it by anatomy and physiology into dilated cardiomyopathy, hypertrophic cardiomyopathy, restrictive cardiomyopathy, Arvc, arrhythmogenic cardiomyopathy, the most common one or the most well-known one being right ventricular, and then unclassified, which includes LV non-compaction and stress-induced cardiomyopathy. In 2008, when the ESC reviewed these, they kept actually these headings and further delineated them as to familial or non-familial based on genetics. So that's primarily what we'll go over. But just to show you how things have changed over the years, cardiomyopathies can be classified by etiology, whether it's infectious, causes of cardiomyopathy, viral, you have a host of things here, toxins causing cardiomyopathies. And this, of course, is an extensive list that we won't go over, but as you can see, this classification of cardiomyopathy is it's still, we don't have the best terminology to really discuss or talk about these, unfortunately. This was the classification in 2006 based on organ involvement. So this was classified as primary cardiomyopathies, which primarily involve the heart, and then secondary cardiomyopathies, which is on the next slide, which I'll show you. And then under primary cardiomyopathies, they divided up between genetic causes and acquired causes, and then mixed somewhere where it could be both. And so it's similar, these are similar things, hypertrophic cardiomyopathy, Arvc, dilated cardiomyopathy under mixed, just classified in a little bit of a different way. This was the secondary cardiomyopathies due to systemic diseases. So you can see here things like lysosomal storage diseases, amyloidosis, glycogen storage diseases. And so these are systemic diseases that can lead to cardiomyopathies. And then this was the ESC, European Society of Cardiology, where they took the initial headings, hypertrophic cardiomyopathy, dilated, ARVC, or arrhythmogenic, restrictive cardiomyopathy, and unclassified, and divided them further into familial types and non-familial. And so it went back to the 1980 headings and then just sort of subtyped them. And this is the order that we'll go in to discuss some of these briefly. This shows the relationships of genes implicated in causing different cardiovascular phenotypes. So again, you have channelopathies, dilated cardiomyopathies, hypertrophic cardiomyopathies, ARVC. And a lot of this information has come out in the recent years as to gene relationships. And so this shows the gene relationships for several phenotypes. The phenotypes are shown in the purple ovals, and the lines connecting each phenotype to the gene or genes of which rare variants have been implicated in causing that phenotype. The gene boxes are color coded according to the number of phenotypes with which they are associated. So the blue indicates one phenotype, red indicates two phenotypes, yellow indicates three. For a gene that causes 3% or more of a familial dilated cardiomyopathy case, the frequency is noted with its name. So well-established hypertrophic cardiomyopathy genes include two sarcomere genes, MYH7 and MYBPC3, that together account for 80% of hypertrophic cardiomyopathy cases for which a genetic cause can be identified. There's three other sarcomere genes, TNNT2, TNNI3, and TPM1, that account for an additional 15% of cases. And so the other numerous genes implicated have caused only one or a few reported cases. So this is an ongoing developing field. Now, it can be a little bit confusing as to the difference between cardiomyopathy and heart failure. And so cardiomyopathy really describes the features of structural and functional heart muscle dysfunction. And heart failure is a clinical syndrome with signs and symptoms. So patients can have a cardiomyopathy and yet not have heart failure if they are asymptomatic and they don't have any signs or symptoms of heart failure. So heart failure is a clinical diagnosis, just because sometimes they do get used interchangeably. So the evaluation for cardiomyopathies is primarily on imaging with echocardiography. And so on echo, you can see systolic dysfunction, which is a decrease in contractility, and it's seen primarily in dilated cardiomyopathies and sometimes in progressive hypertrophic cardiomyopathy. Or you can see diastolic dysfunction, which is an abnormality in relaxing and filling. And we'll discuss more about this when we talk about heart failure with preserved ejection fraction a little bit later. But you can see that with hypertrophic cardiomyopathy, restrictive cardiomyopathy, LV non-compaction. Cardiac MRI in recent years has provided us with a lot of information and is also able to localize iron for hemochromatosis diagnosis, amyloid infiltration, inflammation such as myocarditis, scar, fibrosis, the RV structure and function leading to diagnosis of ARVC. The primary way of diagnosing these is still echocardiography. So now we'll go over into a few of the cardiomyopathies. So dilated cardiomyopathy is dilatation and impaired contraction of one or both ventricles. And you'll see impaired systolic function. And patients usually present with features of heart failure. So shortness of breath, PND, orthopnea, lower extremity edema. And the causes of dilated cardiomyopathy include viruses and gene mutations. And as we said, hypertrophic cardiomyopathy, when it's a burnt out heart, can resemble dilated cardiomyopathy. And again, coronary artery disease and valve disease are other causes of ventricular dilatation, which also have systolic dysfunction. And you'll hear the terms ischemic cardiomyopathy or valvular cardiomyopathy, but these are not defined as cardiomyopathies under the current classification systems. And so these really should be distinguished from dilated cardiomyopathy for appropriate genetic counseling testing. So this again is a long list, blurry, which shows major causes of dilated cardiomyopathy. So again, I want you to remove the thought of this cardiac causes here, because although that causes dilatation of the ventricles, it's not really used to define dilated cardiomyopathy in the guidelines. So you can have infectious causes of dilated cardiomyopathies. You can have medications that can cause dilated cardiomyopathies, toxins, endocrine disorders, systemic disorders such as sarcoidosis, and then end stages of amyloidosis, which is primarily a restrictive cardiomyopathy, can look like dilated cardiomyopathy, and stages of HOCM, as we discussed. And these are genes that are currently clinically relevant for dilated cardiomyopathy. So we do encourage sending patients for genetic testing to see if they have any of these gene mutations. And so this is an echo of echo images of a dilated cardiomyopathy. So you see in panel here, in panel A up here, it's a 4-chamber view from the echo, and in panel B, the echo is from a patient with a dilated cardiomyopathy. So you see in a normal heart, you have an elongated left ventricle. So this is your left ventricle here. This is your right ventricle here, left atrium, right atrium. And in a dilated cardiomyopathy, you can see that this movement is very little compared to a normal heart. And a normal heart is also elongated and more football shaped. And a dilated cardiomyopathy has a more spherical shape or globular shape. And you can see that the geometry of the LV changes. So next we're going to talk.
Sorry, this just a question from one of our residents in the chat. And she's asking, what would be the right terminology for cardiomyopathy from CAD?
So it's essentially heart failure with reduced ejection fraction, if they have a reduced ejection fraction, heart failure with preserved ejection fraction, and that's assuming that they have symptoms. And if they don't have heart failure symptoms and they just have a low ejection fraction, essentially that's systolic dysfunction from coronary artery disease. So the word cardiomyopathy is not used in the classification system. However, as someone, you know, in cardiology, and I'm sure you guys have all rotated on the cardiology services, it is a term that gets used very frequently, such as ischemic cardiomyopathy, and we use it all the time as well. It's just not in the current iterations of the guidelines, which are several years old. So it's very possible that that will change and it will become, you know, ischemic cardiomyopathy will become a classification on its own, and valvular cardiomyopathy may as well.
Thank you.
So next we'll talk about hypertrophic cardiomyopathy. And so this is a clinically heterogeneous disorder caused by a variety of mutations associated with left ventricular hypertrophy. And occasionally you can see that of the RV as well. So this term, hypertrophic cardiomyopathy, is used in a broad sense in the 2006 AHA and 2008 European classification system to include a variety of conditions with increased wall thickness or mass not caused by pathologic loading conditions such as hypertension or valve disease. So it doesn't just include hypertrophic obstructive cardiomyopathy. It can include diseases like Fabry's disease, Noonan's disease, which cause the heart muscle to be thick. And so you'll have normal or reduced left ventricular volumes with this disease, and you'll see diastolic function, especially in the beginning stages. After a period of time, the muscle essentially burns out and you'll see systolic dysfunction, but primarily diastolic dysfunction and symptoms of heart failure with preserved ejection fraction. And so on a histological level, you'll see myocyte hypertrophy and disarray. And you can see that in the pathology slides here, you see myocyte disarray, whereas this is a normal endomyocardial biopsy. And here again, you see that this is the left ventricle. And this here, you see that the walls are much thicker than normal. And mutations in the sarcomeric contractile protein genes are autosomal dominant with incomplete penetrance in most cases. So this would be in the beta myosin heavy chain cardiac myosin binding protein C genes. So again, we do refer patients with hypertrophic cardiomyopathy for genetic testing as well. And see, you see almost cavity obliteration when the heart muscle contracts because the walls are so thick. Next, we'll talk about restrictive cardiomyopathy. Restrictive cardiomyopathy is a non-dilated, non-hypertrophied a ventricle, so it's not thick, but you'll have marked biatrial enlargement. So you see here that the right atrium and the left atrium seem like they're almost the size of the ventricles. Usually systolic function is normal, at least early. And again, hypertrophy is typically absent. Although some infiltrative diseases such as amyloidosis and storage diseases like Fabry's may actually cause an increase in LV wall thickness. So amyloid is a classic restrictive cardiomyopathy in which the LV cavity is small, the atria are large, but it is also, amyloid is also an infiltrative disease and can look like hypertrophic cardiomyopathy on echocardiogram. So it is important to do other testing, which a lot of times includes genetic testing, as well as other imaging studies to differentiate what you see on the echocardiogram. And so again, the causes of restrictive cardiomyopathy can be classified as familial, non-infiltrative, infiltrative, including amyloid, storage diseases, and others such as scleroderma, endomyocardial fibrosis. And restrictive cardiomyopathy is much less common than either dilated or hypertrophic outside the tropics. However, it does cause a lot of death in Africa, India, South and Central America, and Asia because of endomyocardial fibrosis. And that affects children and adults, and the cause is unknown, but it's proposed to include infection, environmental exposure, and immunological phenomenon, as well as genetics. You'll see hypereosinophilia with endomyocardial fibrosis, and essentially endocardial fibrosis and thrombosis. And then moving on to arrhythmogenic cardiomyopathy. So this is structural abnormalities of the myocardium and clinical presentation with arrhythmia. So this could be atrial fibrillation, conduction diseases, ventricular tachycardia. That's not explained, again, by ischemia, hypertension, or valvular disease. So the etiology can be genetic or part of a systemic disorder such as sarcoid or amyloid. So again, you see how different diseases are falling into different classifications. So it's not a clean system really. This can be from isolated cardiac abnormalities like myocarditis causing arrhythmias or infection. Arvc is the first and best characterized of the arrhythmogenic cardiomyopathies. It is primarily genetic, and there are mutations in the desmosomal genes in 40 to 60% of cases. You see a lot of ventricular arrhythmias. the myocardium of the RV free wall is replaced by fibrous or fibrofatty tissue. The LV can also be included in pathology, so it's not just the right ventricle, and you frequently see abnormal RV function. The RV is difficult to gauge functionally on echocardiogram, but a lot of times you can identify this more easily on cardiac MRI. And so this shows a autopsy of a 25-year-old man who died of ARVC. And so this is the heart specimen, and you can see the histology where the myocardium is essentially replaced by fat cells, and it's primarily in the RV. And then there's some cardiomyopathies even after all this that are unclassified. The two largest one are LV non-compaction, where there is an altered myocardial wall due to intrauterine arrestive compaction of the loose interwoven meshwork. This can be associated with heart failure, thromboembolism, because it's easy for blood to pool in these meshes, and can be associated with ventricular arrhythmias as well. So you can see in this autopsy specimen, this is the LV non-compaction. And so you have the compacted epicardial layer and the non-compacted endocardial layer with a lot of trabeculations and deep recesses. And then stress-induced cardiomyopathy is another unclassified cardiomyopathy, which is also known as apical ballooning syndrome, broken heart syndrome, or Takotsubo's. And it's transient systolic dysfunction of usually the apical and or mid segments of the LV that's often provoked by stress. There are other morphologic variants and can include the bases. So now we're going to shift gears a little bit and talk about diastolic dysfunction and heart failure with preserved ejection fraction. So diastolic dysfunction is essentially abnormal LV relaxation and filling that's accompanied by elevated filling pressures. So this can occur with or without associated systolic dysfunction. So when you have systolic dysfunction, diastolic dysfunction is essentially always present. However, in patients that have symptoms of heart failure, but they don't have systolic dysfunction, then diastolic dysfunction is one of the potential causes of their symptoms. And so we went over a bunch of cardiomyopathies. And so causes of heart failure with a normal EF can include the cardiomyopathies that we discussed, like hypertrophic cardiomyopathy, restrictive cardiomyopathy, LV non-compaction. Valvular heart disease can cause heart failure with preserved ejection fraction. Right heart failure can cause symptoms of heart failure with preserved ejection fraction. And then there's HFpEF, and we'll discuss exactly what that means. But that's a clinical syndrome of heart failure in patients with an ejection fraction greater than 50% and evidence of cardiac dysfunction as a cause of their symptoms. So just to go over diastolic dysfunction a little bit. So LV relaxation is a dynamic process. So it takes place during isovolumic relaxation, which is the period between the aortic valve closing and the mitral valve opening, and then during early rapid filling of the ventricle. And then later in diastole, after relaxation is complete, the LV is further filled in a passive process that depends on the compliance of the myocardium and ends in the atrial filling phase. So either active relaxation or passive compliance or both can be impaired in diastolic dysfunction. It is more difficult to identify and quantitate on echo than systolic dysfunction. So it does require, the person reading the echo to be diligent, and the person ordering the echo as well as considering this as a cause of a patient's symptoms. So we're going to discuss heart failure definitions and then talk about the universal definition for heart failure that was proposed recently. So these are heart failure definitions throughout the years from ACC, AHA, European Society of Cardiology, and from 2013 to 2017. As you can see, they they're similar, but they're also different. So you have essentially that it's a clinical syndrome with some symptoms, which are mentioned in some of these, such as shortness of breath, swelling, fatigue, which limits exercise tolerance, and fluid retention, so there's these different definitions, and in order to try to come up with one universal definition, there was a proposal last year, and we'll go over that. So heart failure was classified by ejection fraction in some documents, again, from 2013 to 2017. There's the term heart failure with reduced ejection fraction, which is usually less than or equal to 40%. Then there's preserved ejection fraction, usually greater than 50, equal to or greater than 50. Then there's the thought of borderline, which then was changed to mid-range ejection fraction in the European guidelines. And then there's preserved ejection fraction improved, which is essentially someone who had heart failure with reduced ejection fraction and improved with medical therapy. So these are all the definitions that existed previously classified by ejection fraction. There have been several heart failure with preserved ejection fraction trials, and they've all used different criteria to include and enroll patients. So the TopCat trial, which was conducted with spironolactone, enrolled patients with an ejection fraction greater than 45%. Paragon HF, which is about Entresto, enrolled patients with ejection fraction greater than 45% as well as left atrial enlargement and LVH. Emperor Preserved, which is about Jardiance or empagliflozin, enrolled patients with an EF greater than 40%. Deliver, which is dapagliflozin, greater than 40%. So this is the proposed universal heart failure definition and classification according to ejection fraction that JCF put out last year. And so the proposed universal definition is that symptoms and or signs of heart failure caused by a structural and or functional cardiac abnormality and corroborated by at least one of the following. So elevated natriuretic peptide levels, or objective evidence of cardiogenic pulmonary or systemic congestion. And that includes on chest x-ray or elevated filling pressures on echo or by hemodynamics on a right heart catheterization. And in terms of classification according to ejection fraction, the terminology that they propose is heart failure with reduced ejection fraction, so that's less than or equal to 40%, mildly reduced ejection fraction, which is 41 to 49%, preserved ejection fraction, which is greater than or equal to 50%, and then improved ejection fraction, which is a baseline that's less than or equal to 40% with a 10-point increase from baseline, and a second measurement that's greater than 40%. And so this is primarily the newest iteration and proposal about as to how to use these terms. So this is in this document, they also outline the stages of heart failure. So stage A is at risk for heart failure. And so these are patients at risk, but without current or prior symptoms or signs. And those are patients with high blood pressure, diabetes, coronary artery disease, obesity, family history. Then there's stage B, which is pre-heart failure. So patients without current or prior symptoms or signs, but evidence of one of the following. So structural heart disease, abnormal cardiac function, or elevated natriuretic peptides. C is heart failure, and it's essentially symptomatic heart failure. And D is advanced heart failure. So that's heart failure that's ongoing despite guideline-directed medical therapy. And so those patients require advanced therapies such as consideration for mechanical support, transplant, and if they're not candidates, palliative care. And then this new breakdown of heart failure in remission or persistent heart failure. And essentially the thought is that with guideline-directed medical therapy and modifying risk factors, that symptoms may go away, and therefore that should be called heart failure in remission. These were the prior and still continue to be used stages and functional classes of heart failure. So the ACC-AHA stages of heart failure is very similar to what we just discussed, the proposed stages in the new document. So A is high risk, B is structural heart disease without signs or symptoms, C is prior or current symptoms, and D is refractory heart failure. And so in the ACC-AHA stages, it is progressive. So you go from A to D and there isn't a way to go back. NYHA functional class, which is 1 to 4, is essentially based on limitation to physical activity. So 1 doesn't have any limitation to physical activity, 2 slight limitation of physical activity, 3 marked limitation, and 4 really unable to carry on physical activity without symptoms. And so here, NYHA functional class, you can go back and forth on the scale. And so a lot of times patients will be admitted and they'll be stage C, say NYHA class 3 to 4. And if you put them on diuretics, you put them on medications, you control their blood pressures prior to discharge, if their symptoms are improved, they may be discharged at an NYHA class of 2. So this just shows heart failure prevalence and incidence. And so if you look at these graphs over here, the top shows heart failure with preserved ejection fraction, and the bottom shows systolic dysfunction. And so in here, the red is females and the blue is, let me just make sure that that is right. The red is males. The red is males and the blue is females. So you can see HFpEF is a higher prevalence in females than in males. Again, here, you have incidence of heart failure types by sex. And if you look over here between men and women, red here is HFrEF and blue is HFpEF. So you see here, women, you see a lot of heart failure with preserved ejection fraction more than heart failure with reduced ejection fraction, the opposite in men. So risk factors for HFpEF: older age, high blood pressure, obesity, coronary artery disease, diabetes, atrial fibrillation, smoking. And then, as we talked about, females have a higher prevalence. In some of the statistical analysis that's been done on that, it's been postulated that males have a higher risk of HFrEF, which actually contributes to this disparity, as opposed to females having a higher risk of HFpEF, but that's still to be delineated. So prognosis. So prognosis of heart failure with preserved ejection fraction, there is a high 5-year mortality rate. In some of the studies, it's slightly lower than HFrEF, but in many of the studies, it is comparable to what it is with HFrEF. There are higher hospitalization rates. So here you can see survival, and these are from epidemiological studies with reduced ejection fraction or preserved ejection fraction, and the curves look very, very similar. This is a different study that shows mortality as well, and here HFrEF seems to have a little bit of a higher mortality, but regardless, there is a high 5-year mortality, 50 to 74%, depending on what you look at. These are scores for HFpEF. So this is really in diagnosing HFpEF. And so what you think the probability in A, this is the HFpEF score. And so what the probability of the patient having HFpEF as the cause of their symptoms. So again, these are risk factors that we've already spoken about. And so they, in the scoring system, have been validated to give you a probability based on the number of points. So it includes essentially weight, hypertension, atrial fibrillation, pulmonary hypertension, elderly, and high filling pressures based on echo. And so it'll give you a total number, which then you can sort of plot against the probability of them having HFpEF. This is down here, it's another HFpEF score. It's called HFpEF, and it looks at echo criteria, biomarker criteria, and essentially you get 2 points for major criteria here based on echoes and biomarkers, and then 1 point for minor criteria here. And you add them up, and if you have greater than 5 points, you are likely to have HFpEF. So HFpEF can result from primary or secondary myocardial injury, with the latter being the more typical of the syndrome. So comorbidities are thought to lead to systemic inflammation, which is then associated with systemic endothelial dysfunction and decreased nitric oxide, cGMP signaling that results in secondary myocardial injury. Other diseases such as cardiac amyloidosis and hypertrophic cardiomyopathy can result in primary myocardial injury. So regardless of the cause, LV concentric remodeling and hypertrophy happens, which then results in a cascade of LV dysfunction, essentially, LA dysfunction and RV dysfunction, which then all leads to pulmonary and systemic venous congestion. Systemic endothelial dysfunction also likely contributes to skeletal muscle dysfunction and renal dysfunction, which are both present in the vast majority of HFpEF patients. So these are all like proposed mechanisms. We're still delving into exactly what causes and what leads to this. So HFpEF is also not a clean classification. And so there are different classification schemes and categories that fall into those. We won't go into all of these, but I just wanted to show this to you that, again, this is an ongoing evolving field, and HFpEF sort of is this like grab all term that captures all of this. And yet we need to do a little bit better in terms of identifying phenotypes that are different from one another, but similar to each other in some way, and really figuring out who those patients are and which categories and how they should be treated. But you can see garden variety HFpEF is usually the hypertensive, diabetic, obese patient, can have kidney disease. Then you have CAD associated with it, right heart failure, atrial fibrillation being predominant, and that's with a lot of you'll see that with a lot of patients who have atrial arrhythmias. HOCM. So this is not necessarily that they have genetic forms of hypertrophic cardiomyopathy, but their echo features can be typical of hypertrophic cardiomyopathy. You can have high output heart failure, which is typically due to liver disease, cirrhosis, anemia. Valve disease can again cause heart failure with preserved ejection fraction. And then so there's different classifications, sometimes based on presentation phenotypes, myocardial phenotypes, again, hypertrophic, infiltrative, non-hypertensive, non-LVH. So these are all different, reasons patients could have heart failure with preserved ejection fraction. And then most recently, phenomapping is something that is trying to figure out where patients fall into based on phenotypes, which is an ongoing study. And then when you have a patient who has heart failure symptoms and you do an echocardiogram and they have preserved ejection fraction, the question comes up that is this just, the garden variety HFpEF patient, or is there a clear etiology for their symptoms? And so this is just the differential diagnosis for HFpEF, and remembering this is important because the treatment is different. And so if cardiac amyloid is causing their symptoms, and in cardiac amyloid you have a normal ejection fraction, the treatment for cardiac amyloid is different than just generic treatment for HFpEF. So you have to make sure that you think about these diseases while you're evaluating patients, because how you treat them may be different. And so hypertrophic cardiomyopathy, sarcoidosis, constrictive pericarditis, valvular disease, coronary artery disease, myocarditis, toxins, high output heart failure. So all of these would be treated differently than just heart failure with preserved ejection fraction without having one of these etiologies. And so there's different ways to diagnose these different diseases, but again, you have to have a clinical suspicion for some of these based on history, exam, EKG findings, different studies such as MRI or other imaging modalities. So this is from the 2017 ACC-AHA update of the guidelines from 2013. And so we have had new information from 2017 to now, but this was the recommended for treatment of HFpEF. So the first thing is blood pressure management. Second is diuretics. Third is for patients with CAD, revascularization should be considered if that is judged to be having, to be leading to their symptoms. Third, management of atrial fibrillation properly. So a lot of patients with atrial fibrillation will have symptomatic heart failure, and so managing the atrial fibrillation is important. And then medication-wise, use of beta blocking agents, ACE inhibitors, and ARBs in patients with hypertension is reasonable to control blood pressure in patients with HFpEF. So I'll show you a little bit more in terms of medications in a few slides. And then this was new in 2017 in appropriate patients with HFpEF, and they used an EF of 45, elevated BNP or heart failure admission, and a GFR that's greater than 30 or a creatinine that's less than 2.5, potassium less than 5. Aldosterone receptor antagonist may be considered to decrease hospitalization. And this comes from the TopCat trial about spironolactone, and we'll discuss that. The use of ARBs can be considered, and we can talk about those recommendations as well. And then things not to consider. So nutritional supplements, there's no recommendation. Nitrates or phosphodiesterase 5 inhibitors, there's no recommendation to do that as well. So these are major trials for treatment of HFpEF. And again, we're not going to go through all of these, but I want you to notice here on the side findings. So this is ACE inhibitor, ARBs, ARNIs, beta blockers, MRAs, nitric oxide, and others, digoxin, ivabradine. So most of them are neutral trials, you see. The ones that are positive, there's maybe some data for ARNIs, and we'll go over those in a little bit. For MRA, the TopCat trial was neutral, but there was some geographical variation, and we'll go over what that means as well. And then at the bottom here, there's the CHAMPION trial, and the CHAMPION trial is really for CardioMEMS, and it's PA pressure guided therapy. So you implant a CardioMEMS and you have patients submit their PA pressures from home. And if their PA pressures are rising, you increase their diuretics. And so basically that showed a similar benefit in heart failure with preserved ejection fraction, as well as heart failure with reduced ejection fraction. And their endpoint, primary endpoint, was heart failure hospitalization. And that makes sense because we know that in HFpEF, your filling pressures rise before you get symptoms. And a major problem in HFpEF is elevated filling pressures. So it makes sense that this trial was similar benefit in HFpEF and HFrEF. So the top here is the TopCat trial. And so this looked at the use of spironolactone. And the overall trial result was neutral, but it compared spironolactone and placebo. And if you separate out the regions, and so if you look at Americas and that included the United States, Canada, Argentina, and Brazil. And you look at separately Russia and the Republic of Georgia. So the event rate in Russia and the Republic of Georgia was approximately 5-fold lower than the Americas. So the thought was that there were actually patients enrolled in this trial from Russia and the Republic of Georgia who actually did not have heart failure with preserved ejection fraction because the event rate was so low. And so if you eliminate that data and just look at the Americas data, there is a difference in heart failure hospitalizations between patients who got placebo versus spironolactone. And then the bottom here graph sort of combines Paradigm and Paragon trials. And so those looked at Entresto. And so Paradigm looked at Entresto and heart failure with reduced ejection fraction. And Paragon then looked at heart failure with preserved ejection fraction, enrolling patients with a heart failure greater than 40 to 45, I believe. And so what it showed, so Paragon was essentially a neutral trial as well, but when they did a sub-analysis of it, it did show benefit in patients with heart failure with an ejection fraction less than 57%. So Entresto is now FDA approved for HFpEF, and what you see here is essentially the benefit across ejection fraction. So one is sort of neutral here, and you see this is for men and this is for women, that you get to that around somewhere in ejection fraction between 55 and 60, and then for women, maybe even up to 65. So it shows the treatment effect for Entresto across the spectrum of heart failure from both trials, and the treatment benefit declines as the ejection fraction rises into the normal range for both men and women, but women for some reason derive a greater benefit at a higher ejection fraction than men. So this is similar to the last slide, the last graph, in that it shows the benefits of different drugs that have been studied across different ejection fractions. So candesartan was looked at in HFpEF, MRAs, as we talked about with spironolactone, and then Entresto. And so you can see that the benefit for all three therapies really tends to wane as you get to the higher ejection fractions. These are the newest drugs that we have been using. So these are SGLT2 inhibitors. So the Emperor Preserve trial looked at empagliflozin, and Deliver Heart Failure is dapagliflozin versus placebo. Deliver HF has not yet released its information, but Emperor Preserved came out last year in NEJM and looked at this. Up here shows the primary outcome composite of cardiovascular death or hospitalization for heart failure, which was significantly reduced in patients with empagliflozin, and you can see that here. And it was driven primarily by hospitalizations for heart failure. And so these SGLT2 inhibitors now are medications that we have been using for heart failure with preserved ejection fraction. So really the medications that exist right now include SGLT2 inhibitors, MRAs, and Entresto. And there's ongoing trials. There's an ongoing spironolactone trial looking to see if the results of TopCat pan out. Deliver HF should be coming out relatively soon as well. And so this just is a cartoon that shows, summarizes the barriers and solutions for a successful translation of therapeutics for heart failure with preserved ejection fraction. So HFpEF is the culmination of several risk factors that we've discussed, including age, comorbidities, particularly obesity, AFib, sedentary lifestyle, environmental stressors that lead to multi-organ reserve dysfunction. So the inability for the body to really adequately tolerate this, which involves not only the heart, but also the kidneys, the lungs, the microvasculature, adipose tissue, skeletal muscle. And so the all of this is very complex in terms of the risk factors, pathogenesis, pathophysiologies, multi-organ involvement. So HFpEF is a very heterogeneous disease. And so there has really been a lack of translation, and the majority of the clinical trials, as we saw, have not led to improvement in symptoms or reduction in adverse outcomes due to several potential barriers. And the barriers include inadequate preclinical studies, really irreproducible results, uncertain accuracy if patients even have HFpEF in human studies like we saw with TopCat, this one-size-fits-all approach to clinical trials, this non-specific inclusion criteria, lack of multidisciplinary care. So, you know, there are solutions that people are working towards and try to figure out exactly how best to help patients with HFpEF, designing more phenotype specific trials, targeted treatments, improving diagnostic criteria, biomarkers. But this is obviously an ongoing and evolving field, and we hope that over the next coming years, we have more information so that we are able to help, you know, help our patients with more accuracy. I just have a few questions. So let me see. So I can read through them and then maybe someone can answer or talk about them. So the first question is a 66-year-old male who comes to the ED, 2 days of progressive shortness of breath. His diabetes, hypertension, hyperlipidemia. He takes dapagliflozin, chlorthalidone, amlodipine, aspirin, statin. He's anxious, temperature is 37.4, heart rate's 92, blood pressure 138/80, satting 92% on room air. JVP is 12, lungs have crackles, heart sounds are regular with the summation gallop, abdomen soft, non-tender, extremities warm, no edema. We'll take a look at his EKG on the next slide. His old EKG from 6 months earlier is normal. He has a chest x-ray which shows pulmonary vascular congestion. He has an echo which shows an EF of 65%, mild LVH, normal valves. He has a creatinine of 1.1, a hemoglobin of 12.2, and a troponin of 0.3. This is his EKG. What's the next best step in managing this patient? Cardiac MRI, VQ, PYP scan, which is for amyloid, coronary angiogram.
Could you go back to the EKG, please?
Yes.
Thank you. Yes, I see like maybe like a 1 millimeter ST segment depressions. Like, well, there are some even more pronounced before. That's way more than 1 millimeter. Also B5, B6. Also, I see some maybe 2 and 1. So I'll probably go for coronary angiography, because it looks like based on the prior EF, maybe like heart failure with preserved ejection fraction. We don't know if it changed now since it's 6 months old, but if there is evidence of ST segment depressions with a patient with heart failure, then it's probably secondary to ischemia. So I'll do coronary angiography first.
Exactly. So this patient has ACS, so essentially an NSTEMI. The troponin was elevated. There's EKG changes with ST depressions. The echo shows normal EF, so his presentation, as you mentioned perfectly, is heart failure with preserved ejection fraction triggered by ischemia. So coronary artery disease is very common in HFpEF, seen in up to 2/3 of patients. And so revascularization should be used in the patients of HFpEF and also CAD. So next question. We have a 78-year-old man came to the hospital with exertional dyspnea over prior several months. He's also noticed a 4.5 kilogram weight gain, worsening orthopnea, bilateral lower extremity edema. His past medical history hypertension, diabetes, hyperlipidemia, OSA, and his home medications include aspirin, statin, and metformin. So his BMI is 35, his heart rate is 60, his blood pressure is 146/92, JVP is 12, he has crackles, and he has edema. His echo shows an EF of 50% with LVH, and left atrium is dilated. The right ventricle is mildly dilated with normal function. So in addition to starting furosemide, which of the following is the next appropriate step? Metoprolol, Entresto, hydralazine, isosorbide mononitrate.
Guys, you can also type in the chat.
Oh, yes.
So Nuri is saying B.
B?
Yeah.
Yeah, so this patient has heart failure based on the clinical history. So he had orthopnea, weight gain, edema, physical exam, JVP, crackles, edema. His echo showed preserved ejection fraction. And in addition to managing his heart failure symptoms with diuretics, the furosemide, it's important to treat his blood pressure. So his blood pressure was like 140/90. So you can use Entresto for that. Spironolactone, though it's not an answer choice, is also a possibility for appropriately selected patients with HFpEF. And then if that was also not an answer choice, you could consider just using an ARB. The CHARM study looked at candesartan. And again, we went over how essentially it was a neutral study, but you can use ACE or ARBs for blood pressure control. And I think this is the last one I have. 34-year-old female, has palpitations, no past medical history, takes no medications, no family history of heart disease. Her blood pressure is 98/78. Her heart rate is 62, otherwise normal physical exam. So you do an EKG and you order an echo. This is her EKG. And so, which of the following abnormalities will most likely be seen on the patient's echo? Asymmetric septal hypertrophy, left ventricular apical ballooning, right ventricular dysfunction, or LV non-compaction. So let's go over first what A, B, C, and D actually mean. So this is sort of like a two-step question in that you have to be able to diagnose some disease based on the EKG and then say what that disease looks like on echocardiogram. So you have a young patient with palpitations, really normal physical exam. You have an EKG here. So what is A? What is A trying to get you for a disease process? Asymmetric septal hypertrophy. What is that?
Hypertrophic cardiomyopathy.
Correct. What's B? Left ventricular apical ballooning.
That will be Takotsubo.
Correct. C, right ventricular dysfunction.
That could be arrhythmogenic right ventricular cardiomyopathy.
Right. Exactly. And then D is left ventricular non-compaction. So her EKG, what does that look like?
I don't see like very tall and peaked R waves, so that one may not go for asymmetric septal hypertrophy, but I do see like T wave inversions, so like ST segment abnormalities, B2, B3, let's say B1 as well. Well, there's also B4, B5, B6. Well, not too much.
And what are these? What are these things?
So that is like, usually you can see that with, I think, repolarization.
In the chat, they're saying epsilon waves or Osborne waves.
Yes, yes. So they're epsilon waves. So they're high frequency, low amplitude deflections at the end of the QRS complexes. And as you mentioned, there's T wave inversions in the precordial leads. So those are called epsilon waves, and they are commonly seen with what?
That's in ARBC.
Correct. Yes. So the answer here would be C. Physical exam is often normal in patients with ARVC, and they may actually not have symptoms, but if they do, it's most likely palpitations or syncope due to ventricular tachyarrhythmias. And then your echo will usually show RV dilation and RV dysfunction. And as you mentioned, with asymmetric septal hypertrophy, it's seen in patients with hypertrophic cardiomyopathy, and EKG usually shows LVH. For LV apical ballooning and Takotsubo, T wave inversions can be seen. And in patients with LV non-compaction, usually you have a normal EKG. I think that's the end of what I had. I just wanted to thank you all for having me. And then if you ever need to set up appointments for patients, especially when you're discharging them, you can always email heartfailureRFU@mountsinai.org. And this is our team. If you ever have any questions or need help with patients, feel free to reach out to us.
Thank you,
Any
Dr. Mahmood.
questions?
There's a question in the chat from Eric. He was asking, after achieving a desired ejection fraction, since the effectiveness of the drug wanes and then you have more side effects, do you reduce the dose or do you discontinue the drug?
So in people, so this question more pertains to heart failure with reduced ejection fraction, because with drug therapy, you can get to improvement of ejection fraction, which we said was a rise in greater than 10 and an EF greater than 40. So if you get to heart failure with improved ejection fraction, there is a risk of recurrence with drug withdrawal therapy. So there's a risk of recurrence of heart failure with reduced ejection fraction when you withdraw drugs. So I usually have a conversation with my patient at that time, if they've had improved ejection fraction, about withdrawing drug therapy or continuing it. And if they don't have side effects and they are tolerating the medicines, I usually continue medical therapy as long as I can. If they are having some side effects or they can't tolerate the drugs, or there's a problem that the patient, really doesn't want to take them, I will try to continue up to a year out from normalization of ejection fraction, and then taper as little as gradually as possible, just because that risk of recurrence can be high, and it's not predictable as to who will have recurrence of heart failure with reduced ejection fraction while doing serial monitoring of echo. But I usually try to continue the drug as long as they don't have side effects. If they have side effects, then you can reduce the dose. You can try every other day dosing for some drugs. However, the things that have been studied really have been at maximal doses.
Thank you, Dr. Mahmood. Thank you so much for your time and for joining us today.
No problem. Thank you, guys.
Thank you.